Since then, I've been following her career achievements, and when I have the opportunity to nominate her to go to the school, a friend of the invited speaker series, I immediately thought of her so that I could share the goodness. So please join me in thanking her for coming and welcoming her. And I'll turn it over to you.
Great, thank you. Thank you, and thank you for that very kind introduction. How's everybody doing? Good morning. Good morning. Okay. Great. Can I do myself from here? Or I just want to get that away. Thank you. Thank you so much. Perfect. Thank you. It's great to be here today. Good to see you all. Again, my name is Keshia Pollack Porter. Now, I did not forget the hyphen in the last name. People ask me that all the time. To call me Keshia. I have two short names, Pollack Porter, and again, I bring greetings from Baltimore, which is a train ride away. So come say hello anytime if you're down in the area. And I'm just thrilled to be here. Thank you all for having me. This is not my first time here. I spoke in this. Did I see you up here in the front? Come join us. Anybody? I had the privilege of being here, but pre-pandemic for sure, to give a talk. I think it was during Anna's first 5-year term as dean. So I'm excited to be back and to talk with you about some of the work that I've been doing promoting policies to advance health equity. In our time together today, because I know that there are some students in the room or online, I thought I'd tell you a little bit about my journey into policy, and then I'll tell you why I focus on policy. And then I'll present 3 different examples of sort of how I'm working in policy in terms of my scholarship, but also policy engagement. I spend a lot of time directly engaging with policymakers, with staffers at the local, state, and federal level, elected officials, in order to help to inform and advocate for policies that are going to help to improve health and health equity. And then I'll just end with some conclusions. Certainly happy to take questions along the way, and I will make sure we end on time because people have things to do. All right, so let me just start with a little bit about my training. So I trained in, my undergrad degree was in sociology and community health. I went to school up at Tufts. Before then, I was in New York. I'm born and raised in New York, first generation college. My parents immigrated from the Caribbean to the US, met on a blind date in Brooklyn, New York. And then my brother and I were born, and there we are. And certainly they pushed education for us and saw the belief in myself, particularly from my grandmother, that I could change the world, and I had a gift to do that. And that's really what's motivated a lot of my work. I went, after completing my degree at college, I went right to Yale, and I did my MPH in epidemiology. And I thought epidemiology was the coolest thing until I took a class in policy, and I thought that was the coolest thing. I really wanted to work at the intersection of epidemiology and public policy. How do we do good science and translate it to inform policy and practice? I continued my training, and I remember looking for doctoral programs in either applied epi or health policy and management, and I ended up at the department I have the privilege of chairing now at Johns Hopkins. And I finished my degree and focused a lot on actually injury epidemiology, and had a chance to think about workplace safety and health. And along the way, I've always really thought about the policy implications of my work and doing policy relevant research. When I was a doctoral student, I also interned for the Maryland General Assembly, which was one of those transformational experiences where I worked on staff for an elected official, and I was able to actually see during the session how policy change happens, how research is used or not used in the policy process. And this was in part possible because in Maryland, the legislative session is 90 days long. So in 90 days, every year, all the legislation is passed, right? So at the time, it was about 3,000 bills. Now it's about close to 4,000 bills, 5,000 bills come through in the 90-day session. So I was working on my dissertation, and I spent a few days a week on staff with this elected official doing things like writing policy briefs, writing memos. So all of you who don't like doing those things know it's very helpful and important. And practicing how to write good memos is just such a critical skill. After I finished my degree, I did a postdoctoral fellowship and evaluation at UPenn, actually, and at the Robert Wood Johnson Foundation. And so I was in Princeton at the foundation supporting evaluation for grantees who were being funded through, at the time, the childhood obesity team. and was called the Vulnerable Populations Team. And I really enjoyed the work. I enjoyed going out into community, meeting with community, thinking about how to tell their stories through data in terms of their impact. And I remember reading a lot of grants and making recommendations on funding. And I thought I could do this myself. I missed doing my own work. So I went on the job market and then ended up at Hopkins, where I became an assistant professor, and I had an endowed chair as an assistant professor, which I'm very grateful for, and really began to focus my work on how do we promote safe and healthy built environments where people are being active. I did some active transportation work, pedestrian, bicycle safety, a lot of transportation. And then I also reconnected with the General Assembly, and so continued to work while I was a faculty in the legislature, helping to bring science to the policy process. The person I worked for was the only physician at the time in the General Assembly, so everybody would come to him anytime they had a question about something related to health. So being on his staff, I was able to really get a lot of experience with how do we synthesize science, pull studies together, write briefs to help to inform committee hearings. When I was on faculty, I also started to do some work around health impact assessments, which is one of my areas of expertise. And at the time, there was a group that was funded by the Robert Wood Johnson Foundation and Pew Charitable Trust called the Health Impact Project, housed in DC. And I was a consultant with them for over 10 years, helping to build the use of health impact assessments in the US. And so did a lot of applications of HIAs, or health impact assessments, to policy proposals, and I'll talk more about that in a moment. And finally, as was shared in my introduction, I have the great privilege of being the Bloomberg Centennial Chair of the Department of Health Policy and Management. I know you're HMP here, we're HPM. And I also am a Bloomberg Centennial professor, and I direct something called the Institute for Health and Social Policy. And so we really, in our department, have a group of people who are looking at how health is impacted by social and public policies related to things like firearms, transportation, housing, a lot of the structural determinants of health. So that's sort of my journey, and I like to begin anytime I talk about policy with saying, like, why does policy matter? I have a lot of colleagues who say, I don't do policy, Keshia, and I said, well, have you ever returned something to Amazon or Macy's? We do policy, that's a return policy, right? It's not legislation, but it's still policy. Organizational policies matter, institutional policies matter. So I believe we've all touched policy in some way. And because of that, I'm really motivated to have this be a space where I spend a lot of my time, because policy touches all of us, right? It touches all of us. The other thing I'll say is that policy change, I truly believe, is one path to permanent social change and really helping with long-term systems reform, right? So I believe that we can change policies to help to support people's ability to thrive and to not be harmed. And I'll give some examples of how we're working to do that. I also believe, and there's a lot of evidence showing that we can change policies can help change people's minds and attitudes. We can look at public perceptions about a number of things in this country, and we can see what's happened in terms of policy change, or even in terms of public opinions informing where policy is going. One of the things I did when I worked on staff for the elected official Delegate Morheim, who I worked for in Maryland, is that we would survey constituents to understand people's perspectives about policies. That understanding what the public thinks about different ideas was an important part of the policy process. I also think that policy change can help to remedy entrenched oppressive and racist systems. And as I think about how people have been critical for shaping policies, people can help to undo the wrongs of the policies that exist. And so I'll really think through how we can implement policy that can dismantle structural racism is an important part of my thinking as well. And as I just said, policy is made by people for people, which means that we all have a role. And that's one thing I hope you take away from this our time together today. Is actually we all have a role in policy. How we engage is unique to ourselves, and we should engage in a way that makes sense for us. And that's within sometimes our systems or our rules of our institutions. But again, we all have a role, and I hope that that when you leave here today, you'll feel inspired by that and remembering you have a role, you have a voice in this process. So when I talk about policies, I'm gonna just get us all on the same page. This is the table from a paper I wrote a few years ago about the importance of policy change to address leading public health problems. And this is just a table to make sure we're all on the same page when we talk about policy. So certainly we're thinking about legislation. So for example, laws created by Congress, and we're talking about regulation as well. So regulatory policies. What are agencies putting forward in terms of how we are implementing what some legislation says? Litigation, I'm sure we had a conversation earlier about the importance of the courts. And, people say, well, courts don't make policy. Well, they do actually. Their decisions inform policy, their decisions inform implementation. And then, of course, we also think about executive orders and other types of policies that might not have the force of law, but are important for helping to govern how we interact in society. I also want to remind you of the importance of non-governmental or private or institutional policies, like those Amazon return policies or an employer's policies. People, oftentimes you may have heard of people saying big P, little p policy. I don't use that language, it's all policies. It's just a matter of what is the level it's being enacted at. And they're all important, right? And so when we think about policies, there's opportunities to inform policies at the legislative level, as well as the institutional level, as well as the local school board. For those of you working in education, like there's a lot of policy that happens at the school district level that we can be thinking about. Again, legislation is important, but I just want to remind you, when I think about policy, we're talking about policy broadly defined. In that paper that I mentioned that we published in 2018, we also put forward some principles for effective public health policy change. And in that paper, we talk about the importance of using evidence to inform policy. And so this really gets down to conducting good research, synthesizing that research and translating it to policy and to inform policy recommendations. I acknowledge that this is hard because not everybody believes the science, right? And so that oftentimes there are so many other forces that influence the policy process that no matter how strong the evidence is, those factors such as acceptability, cost, all of those other factors come into play and oftentimes will really minimize the influence of science or evidence in policy. We also put forward as a second principle considering health equity as critical for policies. And I'll spend the rest of my time today really on that and how we can think about advancing and achieving health equity in our policy processes. We talk about also designing policy with implementation in mind. And I think that this is also important. A lot of times policies are put forward without consideration to actually how it's going to be implemented. I like to tell a story of how I was involved in a bill many years ago where it was related to closing a loophole around booster seats for kids, right? So we required kids to sit in booster seats in cars. And so this particular loophole was closed. And part of the conversation around the implementation involved, well, what was happening because people weren't following that particular new law that the state had. Well, nobody was educated about it. There was not a campaign about saying, here's the change that was made. What do you think is another barrier to why people were struggling to implement this new booster seat requirement? Cost, yeah, yes, exactly. Cost was another big issue. So again, now you might say, well, maybe that's not the legislature's job to be thinking about cost in that bill. I disagree, but some people would say that's not their role, but it is their role to partner with agencies and other organizations to think about how do we reduce the barriers to people being able to comply with the law versus relying on law enforcement to enforce and give fines for people who weren't complying. And finally, we put forward the importance of using proactive research translation strategies. And this is really about bi-directional relationships. It's about reaching out to policymakers and also having them reach out to us. I'm in a position where I have elected officials, policymakers reach out to me about studies I've done or say, Keshia, do you have any information on X or Y? And so that's happening as well as myself and our team pushing out our science to people to make sure that we are actively, proactively getting our research into the hands of individuals who can do something with it. I'm sure you've seen many images like this. I don't need to educate this group on sort of structural determinants of health, but why I wanted to show this, and this is an image I'm resonating with now, just to remind us as we think about what impacts our health outcomes. Really where we're focusing on is really thinking about the social determinants of health and these root causes and these underlying structures and systems of dominant culture and narrative. So thinking about the role of poverty and structural institutional barriers. And where I spend a lot of my time in my work in health and all policies, which I'm going to talk about, is here, thinking about how can we target policies in other sectors and how they influence health. Because really one of the issues that I'm trying to solve is that many decisions that are made by these other sectors are made in ways that might unintentionally harm health. And it's not that my colleagues who work in planning or housing are intentionally trying to harm health. It's that their scope of how they view things is from a health lens, right? We have different goals in terms of what they're trying to achieve. But part of what we want to do, or my team, what we do is we really partner and work across sectors to say, how can we lift up health and equity in these decisions that they're making in these other sectors? And so as we think about solutions to this problem, because this problem can be solved, I want to lean into health and all policies for the rest of our time together today and some of the work we're doing in this space. But people heard of health and all policies, HIAP is the acronym, so you want to head nods. For those of you who are unfamiliar with HIAP or health and all policies, this is really a strategy or process that involves integrating and articulating health considerations into policy and programming at all sectors and all levels. And it's really about how do we improve the health of individuals by changing systems, by changing processes to ensure that health is routinely considered. It's a collaborative process. So this isn't about public health coming in and saying, do this or do that, but it's about coming around the table and saying, how do we work together? How do we work across sectors so that you meet your sector goals and we don't harm health? And actually, let's try to promote health. This is a data-driven approach, really informed by the evidence. And by evidence, I mean evidence broadly defined. So a lot of this work, we might rely on what we're learning from systematic reviews of the literature, as well as epi studies, as well as economic analyses, looking at where is the burden, where are the drivers of health inequities in particular. HIAP is a systems level change. This isn't about sort of one-off, let's just make a decision here that thinks about health. This is changing the way we do business. And this process of implementing HIAP has been around globally for a long time, many, many decades. And we see certainly evidence within the US, within the, really, I would say since the 2000s more regularly, but outside of the US, many countries have been leaning into this process and thinking about health. We hear things like healthy public policies or thinking about social policies that are routinely and sort of grounded in health. But here in the US, there's really been a movement to say, we need to be implementing health and all policy strategies. And we have some good examples in this country. And finally, health and all policies really gets to those social determinants of health and those root causes. It's saying, again, if we know that decisions made in the education sector influence health, how can we work with the education sector to make decisions that are going to promote health and not harm health? And I'm just highlighting data-driven here because I wanted to say that as we think about institutions like this and research institutions, it's in other research institutions, it's thinking about how are we getting our data out there? How are we conducting the research and all the research that we're doing and getting into the hands of people who are making decisions about strategies like this? And I'll come back to that to the end of the talk around the engagement part, because that's also part of engagement. It's translating and disseminating our research and our science. When we look closely at health and all policies, and I've studied implementation of health and all policies in a few settings, here are just some of the key elements. Health and all policies promotes health and equity and sustainability considerations. It's a way of supporting, you'll see integration across sectors or intersectoral collaborations. In Baltimore City, one of the prior health commissioners created something called the CAT team, which was the Cross Health Agency Task Force, CHAT. And that involved people from all the different agencies, plus the health representative, somebody from the health department, to come together and talk about what are decisions that they are moving forward that could benefit from a health lens. So when we see HIAP being successful around the world, it's codified in some way. They're bringing people together where they're not siloed. Because we are still very much siloed, even within agencies. Maryland had a health and all policies work group that I was a part of, and there were individuals who were in the same agency, sitting on different floors who had never met each other, right? And so how are we supposed to work together across sectors when we're still so siloed? So these types of agreements really help to break down those silos. Part of that too is also naming those co-benefits for multiple partners. That's part of the value of bringing people together across sectors. HIAP also engages a broad array of stakeholders. So certainly policymakers and decision makers, community members have a really important role in this work as well. So how are we listening to community, engaging with community around the strategies we're putting forward? I mentioned this involves structural or process changes, again, changing the way we're doing business, using tools to help to regularly think about the health considerations. And then again, I mentioned earlier about evidence informed, so using various types of data. And so many HIAP strategies will lean into qualitative data, using other things like photo voice, quantitative data, really a variety of ways to say, what do we know about this problem and how we can think about bringing people together across sectors. And this creates a challenge too in terms of language. You know, when I go talk to my colleagues in transportation planning, I can't talk about p-values and a number of other things. Like I have to think about how am I translating and communicating clearly so that we're all can be on the same page. And certainly HIAP has been demonstrated around the world to help to achieve health equity. And I don't use achieve aspirationally. When we think about what we need to do to achieve health equity, we're talking about changing power structures, and HIAP has been demonstrated to do that, to really challenge existing power structures and bringing voices to the table. And so this is a recent within the last couple of years image from RWJF on that equality versus equity dichotomy, and I like this one now, and just reminding everybody about the importance of equity, where we're giving people what they need in terms of communities, in terms of addressing barriers and circumstances and conditions. And we know that health and all policies can be used to help to achieve health equity, and it's been shown around the world. So there's no one single way to quote unquote do health in all policies. A number of entities will use different strategies. I mentioned that cross-agency health task force that was created. We also see strategies to integrate health into things like zoning policies or different planning processes. We've seen even integrating health language into requests for proposals. Many years ago when bike share came to Baltimore, that request for proposal for a vendor actually included health, included them adding health metrics and health considerations. We also see health-related scoring, grant scoring criteria for a number of funders. We have seen that, particularly the EPA has had some funding where they've had health-related scoring. All right, we'll keep talking. Maybe we'll just fix the, there we go. Thank you. And then finally, conducting health impact assessments and related tools. And I started here earlier by talking about, this is one of the areas where I do some work. And so we'll talk about what I mean by health impact assessments in a moment. Let me pause and see if anybody has a clarifying question on anything I've covered so far before we shift gears a little bit. All right. So I want to just mention, for those of you who are less familiar with health impact assessments, here's sort of a definition of HIA. And an HIA is really a combination of processes and procedures and tools that are used to determine the potential health impacts of a proposal. So what happens in this type of process is we're saying, here's a proposal, maybe a new road. Let's think about all of the ways that when this road is actually coming to fruition, health could be impacted, both positively and negatively. And HIAs have been around for a long time. People might be familiar with environmental impact assessments, which certainly have law behind it for certain project sizes. There's the NEPA, the National Environmental Protection Act, that requires these environmental impact assessments. And really there was a recognition that HIAs, that human health considerations were not part of these EIAs. So if you've ever seen one of these things, they tend to be really large, several hundred pages, and they'll talk about what's the impact of that project on environmental health, on land, on air, on water, but less attention, hardly any, to things like inequities, to social impacts, other types of impacts. And so there was a real recognition to say we need to be bringing in health into this process. And we've seen HIAs, again, have really developed outside of the US. I teach a course, I started a course about 2010 on health impact assessments that I teach at Hopkins. I just finished, we got 123 students in class this year, learning how to do HIAs. We work with a real partner out in the field and we worked with our Department of Transportation this year on a project where the students worked on rapid health impact assessments to then inform some decisions that are coming up for DOT, where they surprisingly don't work a lot with health. But we would think, of course, it's related to the built environment. Health is at the table, not so much. And so certainly HIA is a really pragmatic tool. And one of the things that we've seen in our work is that HIAs have really been helpful for lifting up for policies. And there weren't a lot of examples at the time about HIAs being applied to policy, but this has really been an area where we've seen a gap. So HIAs have really been applied to projects and to different types of plans. And I mentioned earlier, I spent time in the legislature and I saw this real need for health impact assessments and related tools for policy. I won't sit too much on health impact assessment, but just to remind you, and I want to just ground you for where I'm going next, is HIAs have a process that involves a number of steps, and I just want to name that there is a structured process, and HIAs can also be applied to decisions that are really rapid, and the scope of this process can be something that takes just a couple of weeks in what we call a rapid HIA to something more comprehensive. So I've worked on a comprehensive HIA of a federal proposal for changes to SNAP, the Supplemental Nutrition Assistance Program. So we did this for a few $100,000 over multiple congressional sessions. I've also done this in 2 weeks for a decision that was on the table in Baltimore. And the goal here is about informing the decision. This is not an academic exercise. It's saying there is a decision that's going to be made where health is not at the table. We need to bring health to the table, and so we use a tool like this to do that. One thing I'll just mention is that really what impacts the scope differences I'm talking about is stakeholder engagement. So stakeholder engagement is critical in the HIA process. And when you only have a couple of weeks to do a rapid one because you want to inform something, that's not going to be very deep. You can imagine when we did a comprehensive one over years, we did national engagement. We did focus groups and engagement across the country. We had a lot of partners, a lot of resources. But in order to be useful, we also wanted to make sure we were paying attention to the timeline where we could influence what was happening. And so I just mentioned there's actually one type of HIA called rapid HIAs, and we're seeing this actually being adopted around the country quite a bit. And so for us and our team, we do this, and in the over here in the assessment phase, this is where sort of the methods of HIA are, and those can include a number of methods. And so for a rapid HIA, it's pretty much a rapid literature review and then pulling together existing data, right? So you're saying, all right, this decision is going to be made in a few weeks. What do we know about all the ways this proposal can impact health in a positive way and a negative way? Going to the literature, synthesizing that, pulling some available data when we can, because we really want to be timely here. There's an example of a rapid HIA that I've been working on with on the west side of Baltimore. They're doing some redevelopment. And so what we ended up, they said, Keshia, can you add this rapid HIA? So I'm working with the transportation engineering company as a consultant. And what we did is we, in order to engage a community, there were some community meetings. And so we just asked people, so we're at this meeting, we had some surveys and we said, all right, they're gonna redesign this road here. What are all the ways you think this could impact health? People lifted up, crime, housing, pedestrian safety, all of these areas. And that went into our rapid HIA to say, here are the ways that health can be promoted or health can be harmed. And we pulled together the literature, pulled together some existing data in the neighborhoods that the people in that community said were part of their community. And then we also synthesize that into a couple of pages in a longer report. We're in the second phase of this now. We're going out to do some additional proposals. We're looking at specific proposals by the city. And it's actually been a really important process because individuals in the community, they care about these health impacts, right? They were excited that we were talking about the ways that health could be promoted during this redevelopment process in West Baltimore. If you're interested in learning more about HIAs, let me say that there's a whole database online. It used to be housed at the Health Impact Project at Pew. It is now housed by the Institute for People, Places, and Possibility, IP3. So if you go on this website, hia.communitycommons.org, you can search for HIAs by topic, and you'll see HIAs that have been done across the country. There's about 450 in this database so far, different scopes, different topics. So if you're interested in learning more, I point you to that resource. So, and there's actually one other thing you'll see here too. There's actually been a number of evaluations of health impact assessments. I've been involved in some of those. Those will be here as well. People always say, are they effective? It depends on how we define effectiveness, right? But I will say HIAs have been shown to change perspective, to change consideration of health. It is very hard to say, did this HIA impact health 10 years from now? But we could see changes to the built environment or projects for things that were mentioned in the HIA. So again, if you want to learn more, I encourage you to go check out some of those and feel free to reach out to me afterwards if you have questions. So HIAs is one way to advance or achieve health equity. And my passion is around policy. And so we were trying to do these rapid HIAs in the Maryland General Assembly. And earlier I said our sessions are 90 days long. So what does that mean? It means by day 45, bills have to cross over from the House to the Senate and get out of committee. And that's not a lot of time. So sometimes a bill is proposed and you have just about 10 days to do an analysis, and a rapid HIA just wasn't feasible all the time. And Maryland, like many states, for bills require fiscal notes. And a fiscal note will say, here's the projected fiscal impact of this bill on the state if this bill moves forward. And early on, maybe about 2014, 2015 or so, I was talking to a colleague after spending a day at the legislature frustrated by a bill, and I said, we need a health note. He said, what do you mean? I said, we need like a public health note, is what I said at the initial time. Like a fiscal note, but about public health impacts. And therein began the journey to create something called a legislative health note, which we are testing around the country now in a number of jurisdictions. So it's like a fiscal note, but for health. And so I'll talk to you, and built on the process of HIA. So that circle I showed you, we're using a lot of that methodology with some changes. So we are really using the legislative health note to advance health in all policies. This work was initially supported by the Health Impact Project. And we started with the pilot effort where we reached out to partners at the National Conference of State Legislatures and recruited some states to partner with us. And we partnered with Colorado and Indiana initially, places where they were sort of different in terms of politics, and places where they were sort of had strong presence of policy organizations where they were least used to seeing evidence. And so we thought this was a good foundation for us. And we then also, through another mechanism, partnered with groups in California and North Carolina, where we went ahead and trained groups to do these legislative health notes. We also developed a methodology. So again, these are all online. You can go on and get our methodology about how to do one of these health notes, beginning with the screening process. The formative work that went into this involved a number of stakeholder interviews and conversations with people across the country who are deep in policy analysis, as well as an evaluation of something called a health impact review that was being done by Washington State. So I don't know if people have heard of an HIR, but this particular tool was the closest thing out there to what I had envisioned. And an HIR was put forward by the governor at the time, and it required the Board of Health to essentially have the health department conduct an analysis of the potential health impacts, particularly for health disparities, for a bill that was proposed in Washington State. And it could be a budgetary change or a bill. And at the time, only elected officials of the governor could request one of these things. And the Board of Health had to conduct it and finish it in about 14 days during the session. And so we went out to Washington State, this was before the pandemic, and we analyzed this, and we wrote up a paper about this, but basically we did key informant interviews, document review, and to understand how was this tool perceived by people. And it was completely seen as a political tool. It was fascinating. Everybody said you asked for one of these if you want evidence to move your bill forward. And people thought you would ask for one of these if you wanted your bill, somebody's bill to be killed. And so you would have all the evidence against it. And part of the reason why it was seen that way is that, there's politics involved in who's the commissioner of health. And they also did this analysis in Washington, on every bill, no matter if it was requested or not. And I think one of the changes or one of the challenges is not every bill needs an analysis like this, or should. There might be a dearth of data where you can't actually do an analysis, but the Board of Health had to sort of respond to every request. And so it was fascinating to learn how people perceive this. And we thought, how can we build on those perspectives in what we were creating? So for every single bill that comes across us, and we will screen for those, and I'll talk about that in a second, what we do is we initially read the entire bill, and we do an analysis of the proposal. And we break that bill down into its components and goals. And then we're essentially creating a pathway diagram to say, here are all the ways this bill could impact key drivers and determinants of health. And then ultimately, here are the health impacts. And so we draw these in a way where it's sort of very linearly looking to see how the bill can affect health outcomes. And we try to do this in a way that's clear, because the target of these are non-health people. The value in doing this analysis is for non-health bills coming through non-health committees. And we decided to focus there because a lot of times there's attention on the health bills coming through health committees. So if you think about, most state governments have a legislative affairs committee or government affairs team. They're tracking what's happening in the health committees. But what they're not tracking is what's happening in the committee that health bills aren't front and center. So we saw a lot of value for highlighting those bills that had impacts for health, but were coming through these other committees. And so what we do during our analysis is really, the crux of it is this rapid literature review. And what we do is we synthesize and summarize the strength of evidence for all of these pathways related to those bill components. And we adapted some of these and actually built on them from the Washington State, our work I did that I just mentioned. And so what we do for every single pathway is we'll say whether or not the pathway is not well researched, or if there's mixed evidence, strong evidence, very strong, et cetera, and really trying to help the policymaker understand, if this bill goes forward, here's how health can be impacted. One of the things I want to share that really is important for this analysis is that we do not make recommendations on how to change the bill. And that's intentional for two reasons. One is it allows us to not cross that line of lobbying. I'm not a registered lobbyist. I'm a person who can educate and advocate all the time. And so we do that. The second reason relates to what we found out when we evaluated that Washington State example, where a health impact review was looked at as a political tool. And it's because people thought they were just trying to change the bill. And I remember talking to, in our interviews, talking to an elected official who said, it's great for you to tell us what the evidence says, but we were elected to make the decisions. And I said, I appreciate that. I respect your role. That being said, we're still going to do what we can to help to bring the evidence to bear to inform how you make your decisions. And so so the Health Impact Project sunsetted at Pew last year, and have moved this team into my center at Hopkins. So the Institute for Health and Social Policy, we now have these legislative health notes. We've posted all of them. They're all available. You can take a look at one of them if you're interested. And we are in the process now of, we've since worked with other jurisdictions aside from the states that I mentioned. We've been doing a lot of work at the local level as well. Washington, D.C. City Council has been somebody we're working a lot with around different bills at the local level and doing these analyses. And part of our dissemination is we go to the bill hearing and we testify and we share our findings in the analysis of the analysis. We of course evaluated this as well. There's a paper actually just came out online, where it's the Legislative Health Notes preliminary findings from it's in Journal of Public Health Management Practice. And my colleague Stephanie Kerrigan's the lead author on that. And just a few things we found out through our evaluation of our health note to date is that we certainly confirmed it's a useful way to advance health and all policies. People kept telling us this type of tool brings health considerations to those non-health related bills, helping people to see the connection between health and education or transportation, things that are obvious to us. We also heard that it was how we presented the evidence was really easy to understand. It was interesting. We heard that the level of detail was appropriate, but they thought only for people who actually cared about the bill. It sort of makes sense, right? People who don't care thought it was too much information, but the people who cared a lot about it thought it was appropriate, and if you didn't care about it, that's back. Thank you. They thought it was too much. We heard a desire for cost benefit analysis, which was interesting. So we also did not include cost benefit analysis in this because what we learned in the states we were working in, there were other groups that were bringing the cost benefit data to this tool. And we thought, well, our added value would be to bring the health information. But we are in the process now of looking at, are there times where we want to bring in some of the cost data into our analysis in one tool? And we also heard really one of the greatest values of the legislative health note is the summary we do of the evidence. Committee staff were like so excited that we have public health expertise where we're bringing evidence together and synthesizing it in a way that they just don't have that knowledge. We all know how to read literature, how to synthesize and make sense of it. And there are people who just don't have that expertise. And so they thought the assessment of the literature was so important and something that we could lean into doing more, particularly for committee members who are looking at these bills. And so really excited about the legislative health note. That work continues. And I guess it was about 2 years ago, I had another random comment to somebody. It was around how do we actually do this also for the judicial process, thinking about the important role of courts for policies. And I've certainly been involved in writing amicus briefs on different bills, which is important for bringing health data to the courts before the decision is made, right? So we've written these on a number of issues that are relevant for health to try to get health considerations to be considered by judges. But one of the things that I realize is that there's really little happening after the decision is made. Certainly people are evaluating sort of long-term impacts of decisions on health, but there's this, I perceive to be this sort of sweet spot in between when a court decision is made and when we have those long-term health evaluation data, where there's a space for health. And so we came up with we're testing a new tool called the Judicial Health Note, using the concept of the health notes on legislation, but on court decisions. And really the rationale is that we know how important judicial rulings are for health and equity. And we also know that we really want to do more than just submitting those amicus briefs. And so we have some funding from the Bloomberg American Health Initiative through something called the High Impact Project, where we are developing, applying, and testing health notes for judicial decisions. So came up with a process to screen decisions based on sort of availability of evidence, a number of other factors. And we are looking for what are those often overlooked health impacts, potential health impacts of a decision that's in front of a court. And the goal is to take those findings and to share them with stakeholders. So this involves doing a stakeholder analysis and widely disseminating it to people who we think could inform implementation of a particular bill. And again, we're doing this on decisions by courts that maybe health is not so obvious. And so, for example, we just finished our first one, and I was reviewing it earlier, and it's on firearm access. You might say, well, Keshia, that's so clearly connected to health. It's homicides, right? No, there are actually a lot of decisions that courts are making where we need to be thinking about other outcomes besides homicide. There are lots of decisions around firearm access where the focus is on legal right to bear arms, where we're not thinking about other impacts related to mental health, related to access or connections with addiction and other issues. And so we're trying to lift those up. Right now we're doing 3 of these. We're still trying to pick our case for adolescent health, but our second case is around CAFOs. And again, looking to see what are some of those, where are those places where health is not being lifted up? And again, the focus here is really on implementation once that court decision is made. So maybe we'll have me come back next year where I'll tell you what we've done, because we are actively involved in this right now, and I'm excited about it. We're developing a website too, where we will post these, and just really wanting to get the methodology out, increasing use of this tool. So if you're interested in sort of health and all policies and these tools that I just talked about, we're actually having a convening in DC in a few weeks. Hopkins has a new Bloomberg Center that's at 555 Pennsylvania Avenue, where we are actually doing a convening around health and all policies. It's in person only, but it's free. If you're in DC on Friday, May 10th, come on down. We're actually having we're bringing together people from across the country who are using these types of tools together with some targeted individuals from the Hill. We're coming to help to promote some of the use of these tools for federal level decision making. Several years ago, I worked with somebody who was on the House around legislation to require testing of some of these tools, and then they weren't reelected. So all that energy and time they had spent working on it sort of stalled. So we're trying to get some new champions. And so this is part of that effort to get some new people to think about these issues. So I want to just end by talking a little bit about policy engagement. And this to me is sort of the third way that we can help to achieve health equity. And in my scholarship, I spend a lot of time engaging with policymakers, and I say a lot of time because it is a lot of time. So certainly write the papers, publish them, write the briefs, and then actually go and spend time with policymakers at the local, state, and federal level. Last year, we published a book called Policy Engagement, and I think there's a copy right over there that you have that passed along, and it's a small book intentionally. It's actually written for public health people. We wrote this for public health practitioners who have, many of them have reached out to myself and colleagues throughout the years and have said, how do we do policy engagement? My colleague Shelley Hearn, who is the director of our Center for Public Health Advocacy, I told her she wore me down. I didn't have time to write a book as new chair, but it was important for the field. So we wrote this book and pulled in another colleague, and the book really sort of just goes through a number of basically 101 for policy. We're actually starting to think about a 102 book right now, but I want to just tell you a few things, a few highlights if you don't read the book, but I'll just give you a few little highlights. We named these sort of 5 guiding principles to policy engagement. And I'll go through these in a moment, but they are, policy making is messy. People talk about policy making being like making sausage. I don't like to use that because sometimes people are vegetarian, didn't know that. But I just say it's messy, right? It's messy. How you engage is personal. Lobbying is not a dirty word. Your message should align with your audience, and policy making takes a village. Let me just go through these and I'll give some tips for each of those. So the first principle we have about policy making is messy. This is where it really emphasizes the fact that policy making is not a linear process. I've worked on bills that have spanned multiple sessions. It's been amended. The person who's pushing forward doesn't get reelected. I mean, there's just a lot of stuff that happens, right? And really, one of the things that we remind people of is know what your North Star is. Keep engaged, stay focused, and remember to stay focused in the mess, because it's really easy to get discouraged when you're in the mess. And the persistency, being persistent is so important, because it takes a lot of time actually for a bill to become law, particularly if we're thinking about at the federal level. And that could also be discouraging. After the 2016 election, a few of us wrote a paper called Go Local, to remind folks about the importance of local policy change, that even though things might be solved at the federal level, our local policies are really important. And we also talk about being strategic, and I have come to learn this in my work. There's no permanent enemy or ally in policy. And there might be people we disagree with in terms of values, in terms of perspectives, but sometimes the person who's been fighting me the most is the one who's calling me a week later because I have something that they need. And that's been pretty interesting. Somebody I might have had on my list of, no way, I am not talking to you. Because I've had those stories where people have, I will tell you a story. I was on the Hill engaged in a bill, doing some advocacy work, and I was talking to somebody, and even before I left the room, my paper was in the trash. And you can imagine, as a New Yorker, I was very upset. But I knew that I needed to just keep my composure. And but no, seriously, like I knew that that person clearly wasn't resonating with what I was sharing. But when they called me a little while later about something else I had, I was just reminded that that person didn't have to remain on my bad list. Because there are no permanent enemies or allies in this space. You never know where people might connect around an issue. Our second principle we lay out in the book is how you engage is personal. And this is where I like to tell people, like, there's all forms of engagement are needed. So whether you write an op-ed, whether you go knock on doors, work on campaigns, or whether it's translating your information to that policy memo, whatever it is, do whatever you're comfortable doing, but I encourage you to do something. Because what happens is if those of us with knowledge are not engaged in the conversation, people who don't have that information are, and they are creating a narrative. They're creating the narratives that are harmful, that promote oppression and injustice, and contribute to exacerbated inequities. And I have learned that it's so critical to be in these spaces. The third principle we put forward in the book is aligning your message with your target audience. And this involves, first of all, just being your authentic self when you show up, and also being credible. When somebody asks you something, it is absolutely okay to say, I don't know, and I will find out and get back to you later. Because our credibility is something that's so important as we show up. So keep to the facts, keep to the evidence and real world experiences. I do a lot of Hill visits, sometimes with people from community, from advocacy organizations who have a different story to tell and complements mine really nicely. We're not expected to represent every single person, so figure out who's on the same page as you and promoting the same types of issues. And it's really been helpful to be in community with others doing this work. And then also think about when we go to meet with people, do your homework in advance and figure out what do they care about. I have certainly realized that there are people I've gone to meet with who might not be engaged in the issue I'm there for, but they are engaged in an issue on the periphery. So they might not be really invested in an issue related to food security for adults, but if that issue affects kids and they're a champion for kids, I will come in and talk about the value for school meals and school breakfasts. And so thinking again about how do we connect on people to get them to be engaged with our issue is really important. We also talk about how lobbying is not a dirty word. I mean, we actually the three of us who are authors on the book were out in Colorado last week at the American Public Health Nursing Conference. We did a plenary on policy, and so many people are like, I can't lobby. We're not asking you to lobby, we're asking you to educate and advocate, and you are absolutely allowed to do that. And so, you know, we certainly lobbying fears are not a reason to avoid engaging. We encourage people to still engage, but know the rules of where you work. And certainly advocacy or policy engagement is not necessarily lobbying, and there are ways to be engaged and advocate without lobbying if that's one of your concerns. And then finally, we talk about how policy making takes a village. I always ask people, who are your people? You don't have to do this alone. There are lots of us out there who engage in policy work. And so find the organizations that are known to be effective and credible and align your efforts with theirs. You can bring a lot to their work. They can bring a lot to your work. And certainly also engage with your policymakers and be a resource. I've developed relationships with policymakers over the years where people call me and ask me for things, I can call them and ask them for things. And it's really been an effective bi-directional relationship where we are working towards a similar goal. This is our comms team put these together. So we drop everything and read our book. These are my co-authors here, and we've been just having fun putting this book out. It's high on the list of APHA Press, so if you're interested, scan the QR code and you can go to that page. And if you're a member of APHA, it's even less. We don't make any money on this. Let me say that. I'm not trying to promote book sales. I make money. I just think it's a good resource. So I wanted to just say that. So as I'm coming to the end of my time, because I know we're going to end shortly, I wanted to just say a few things. The other thing I get a chance to do in terms of policy is I run a national program for the Robert Wood Johnson Foundation called the Health Policy Research Scholars. RWJF many years ago funded a number of leadership programs as part of building a culture of health. And HPRS, the national program, sits at Hopkins, and I have the privilege of being the director of that program. And really what we've been doing since it was founded is really helping to build a cadre of leaders in doctoral training from various disciplines to think about health and health equity and policy to help to achieve change. And so We are in the middle of just selecting our 8th cohort for this program. These are several hundred individuals now. They come through for a 4-year experience. We'll have one more cohort that we'll bring in, cohort 9, and then this program will end in 2029. Will be our sort of 10-year journey where that will end. But it's really just been a program that's, I think, really been transformational in terms of individuals learning about policy and how they can get those skills, writing op-eds, doing Hill visits, all of those things are part of the program. And this program is really focused on how do we help to achieve advanced equity and equity. So that's it for my time. I hope, going back to where I started, you feel like excited about engaging in policy, about the point I made about how your voice matters. And I encourage you to reach out to me if you'd like to have a follow-up conversation. I know I won't get a chance to meet with everybody today, but would love to follow up if you have questions or comments. And thank you so much for your attention. Thanks for your time. I appreciate it.
Thank you so much. Truly fine and motivating. So there's one question in the chat. This is the Brent Langelier, who is a faculty in the Department of HPM, or I really like the idea of the strength of evidence assessment, and was hoping if you could expand about whether they work from any type of guidelines or framework for making those assessments.
Yeah, thank you. So we certainly, yes. So the framework for how we look at the strength of evidence and summarizing that for policymakers was one built on the Washington State Health Impact Review, and then also what we know about evidence for systematic reviews. And so we certainly relied on some of those best practices in how we summarize information in terms of based on study design, looking at quality ratings. Like all of us who helped to be involved in it have published systematic reviews before and done those. So we really relied on those processes of rating descriptive studies through those RCTs. And how do we pull that together in a way that's clear for a non-scientific audience?
Great, excellent. Yeah.
Yes. Thank you so much. So many things I want to ask about, but we have a lot of experience in the school with collective impact. And I was just wondering, and there's a lot, we were part of the Westfield Promise neighborhood and the Burn Criminal Justice Award here in Mantua. I'm just curious what your best practices or best models are for the cross-sector collaboration of health and all policies and other work like that, and what your experiences with collective impact, or if there are better models to use.
Yeah, that is such a great question. I will say so much of what I've learned about working across sectors has been like on the ground, like where we make lots of mistakes, right? And then try to figure out how to do it better. I have to say one of the things, and this isn't a framework or a model, it's just an insight that was shared with me from a colleague in planning. We were trying to figure out a way to strengthen our relationship. This particular colleague said, Keshia, we're talking about all these ways to work together, but quite frankly, the health metrics are not part of how I get paid. They're not part of my promotion. So you're asking me to think about health when my paycheck has no dependence on that. So if you change that for me, of course I'm going to think about how to improve your health outcomes. How do I do that, right? Like that's at a whole nother level of trying to change systems, but it was so fascinating to hear the people on the ground, like going just to that very pragmatic level, saying, no matter what frameworks we have and how we're sharing power, collective impact, all of these things, they're like, I need you to do this. So that way I feel like it's part of my job and not something extra I do on the side. So that's been one of the things. Another thing I'll say that's been really effective is I have found too, a lot of the times the people engaged in health and all policies are not the agency heads, so not the leaders. They're the people who are on the ground doing the work and we want them involved, and they might be champions. But how do we actually convert the people at the quote unquote top, the people at influence and power, has been the place where we don't do as much work. And I have found that I need to spend more time there influencing those agency heads, all the way up to the governor at the state, because what happens is, again, the people on the ground are all in, but when they go back to their organization,
their boss might be like, what are you doing? Like, why does that matter? So I feel like we need to focus there a little bit. So some of it's about like organizational, I think, theory and like behavior, like those, I think that literature and framework will be more helpful in health and all policies, and I haven't seen a lot of that yet.
Agreed. Thank you.
Yeah,
Yeah,
thank you.
last question, Greg.
Thank you so much for all of this. It's like extremely aspirational for a lot of us to be so deeply involved in decision making. And on this last point, I feel like a piece missing for me as I think about doing this work is like most of the time that upper level leader is pushed not by evidence, but by political movements. Who might use the evidence we have to make their arguments. So how do you think about communicating political movements and educating political actors who then could move decision makers, not on the basis of the evidence per se, but on the basis of, say, what that evidence has done for pushing a conversation that puts pressure on that?
Yeah, I so appreciate that. And I think to me, I take away from your question, so the importance of narrative and narrative change, one, and then for me, the other part is around organizing and getting community together. I think both of those go hand in hand. I think that we need to be connecting and having, I believe in the power of movement. And how do we actually get people to come together around issues and organizing and mobilizing to help to change that narrative? Because that's the long-term work, because ultimately somebody's term will end. Some people have term limits, right? And that they won't be able to stay around. But the people on the ground can continue to be pushing, even whether somebody loses an election or not. It's the people who are staying there and the people who care about these issues. And so I think that's a place where health and all policies has been, has varied in terms of what's the connection with folks on the ground, with organizing, but certainly changing narrative is so critical to this work. I mean, at some of the times I go to places and I have to begin by talking to people about how does housing connect with health? Like that's where I have to start sometimes. Like I talk to elected officials and they're like, oh yeah, health matters, Medicare, Medicaid. I'm like, yeah, Medicaid is really important. Absolutely, it's a big part of your state budget, but I'm not talking about that. I'm talking about all these other ways that health is influenced. And so that's a very basic part of the conversation. And I feel like as public health folks, we need to begin there with the narrative and then really work with folks on the ground to help to continue to support that narrative change. I hope that speaks to your question. Thank you.
Wonderful. Well,
Thanks
with that,
so much.
thank you